So in case a patient is on volume control ventilation, so how are you going to wean the patient off? So you are going to slowly decrease the support given by the ventilator, right? So you are going to, we set the breath rates, right? We said that so many breaths has to be given by the machine. So probably you set around 24 rates has to be given. So 24 per minute. What you do, you try to decrease the breaths that is given to the patient by every 2 to 6 breaths per minute. This is also judged clinically only. So you decrease it every 2 to 4 hours till it comes to the normal respiratory rate for age. Do not decrease much more than that. This is respiratory rate you are going to decrease. Next, the support that you give. Either it can be a pressure support or it is a PEEP. So you keep decreasing it by decrements of 2 centimeters of water every 2 to 4 hours. When you are decreasing the pressure support and PEEP that is given to the patient, make sure the tidal volume is maintained at least more than 4 ml per kg. So this is very, very important. So the tidal volume is maintained in these patients. The saturation should be maintained more than 90% and FiO2 should be maintained less than 40%. So this is how you wean in a volume control ventilation. So how do you wean in a pressure control ventilation? Pressure control ventilation also you set up respiratory rates, isn't it? So you keep decreasing the respiratory rates. You decrease the pressure support. In pressure support, you fix a PIP, that is PIP, and you fix a PEEP, PWEP. So both these pressures have to be decreased. When you decrease the pressure, make sure the target tidal volume is attained at least 6 ml per kg. Meanwhile, the FiO2 should be stable at less than 40% and the saturation, that is SpO2, should be maintained more than 90%. So whenever we wean off the parameters slowly, so you decrease the pressures, you decrease the rates by every 2 breaths per minute, every 2 to 4 hours, you have to look at the patient. Is the patient developing any retractions? Any ventilator and the patient asynchrony is there? And work of breathing, if it is increasing, is there any increase in heart rate? Is the patient developing new onset tachycardia, tachypnea? All these parameters have to be seen in the patient. So when do you consider it as a weaning failure? When you're trying to put the patient on trials and if the patient's heart rate and respiratory rate is increasing more than 20% of the baseline. Okay, so the tachypnea and tachycardia, if it is increasing more than 20% at baseline, then it is a weaning failure. When the patient is in respiratory distress, he has increased work of breathing, you have to stop the weaning process. When always before you start the weaning process, do an ABG, and during the weaning process, 2 hours later mostly, you repeat this ABG. When there is a PCO2 hike, when there is a rise in PCO2, it means there is a weaning failure. The patient is not able to ventilate properly. Okay. So these are all considered as weaning failure. Okay. So sometimes, yes. Okay. So what is this extubation readiness trial, otherwise called as a ERT? So now you have assessed that the patient is ready for weaning and all, right? And you are trying to decrease the ventilatory parameters. So the patient on the minimal ventilator parameters, the patient is comfortable. Okay, so there is no tachypnea, there is no tachycardia. Now you will have to extubate. So suddenly you cannot remove the tube, isn't it? So instantaneously you cannot remove the tube. You have to give an extubation readiness trial. So in extubation readiness trial, usually we follow the TP's trial, or sometimes we can follow the pressure support trial. So what do we do here? Basically in extubation readiness trial, what you are going to do is, when you give a T-piece trial, you cut off the positive pressure support. You just have to remove the ventilator, attach a T-piece and attach to the oxygen, right? What we most often we do. Here we are going to simulate the post-extubation conditions. If the ET tube is removed, what the condition will be outside. So that we are trying to simulate here. So every day you can give this T-piece trial, or you are going to give this pressure support trial, maximum up to 2 hours, minimum up to 30 minutes. Okay. So during the trial, the patient should be comfortable. So maybe after half an hour to 1 hour of the TP's trial, if the patient develops so much of work of breathing, he is sweating, his heart rate is becoming high, he is developing hypotension and all, no, you stop the TP's trial, go back to mechanical ventilation, give positive pressure support, right?